Welcome. What were the medical firsts in the Steel City of Sheffield over the last 200 years? We set out to find these in the Overend-Knight series of medical history podcasts, named after two of the founding figures of medical education in Sheffield in the 1800s. As the University of Sheffield Medical School approaches its bicentenary in 2028, each episode in the series will feature medical discoveries discussed by scientists, medical experts and medical historians. Listen to find out about the personalities involved, life in Sheffield over the past 2 centuries, scientific research discoveries, and where some of the medical treatments we take for granted today actually came from.
You're listening to another edition of the Overend-Knight podcast. This series is named after the surgeon Hall Overend and the physician Sir Arnold Knight, who were leaders of the two rival medical schools in Sheffield in the early 1800s. I'm Alan Pacey, scientist, broadcaster and academic, and in these podcasts we celebrate medical discoveries in Sheffield. With me today are two doctors from Sheffield. They both treat heart and circulatory diseases, and they also have an interest in the history of medicine. So welcome to Abdul Hamid, consultant cardiologist from the Sheffield Pulmonary Vascular Disease Unit and honorary senior clinical lecturer at the University of Sheffield, and Will Parker, clinical lecturer and registrar in cardiology at the University of Sheffield. In this episode, we're going to turn to matters of the heart. Whilst there are lots of things we could talk about, we're going to discuss how in post-war Sheffield, internationally important developments were made in heart disease that continue to be relevant to the treatments of today. Abdul, do you want to tell us a little bit more?
By the mid-20th century, there'd been significant progress in improving the health and life expectancy of individuals within the UK, and old killers such as malnutrition, infectious diseases were being recognised and treated. Improvements in sanitation, nutrition and vaccination played major parts in reducing the impact of these illnesses. However, at the same time, there was an increasing recognition of other types of illnesses, and cardiovascular disease was a common and major cause of illness and premature death. So, for example, today in Western Europe, heart and circulatory diseases account for at least 40% of all deaths. And these numbers have reduced over time in terms of the death rates from, for example, coronary heart disease. But at the same token, people are living much longer compared to previous, and so are living with cardiovascular diseases later on in life. Now, the conditions that may have been encountered in the 1950s, for example, would have been conditions such as high blood pressure, what we call hypertension, people who had coronary heart disease, which is narrowing of the coronary arteries. There would have been problems with stroke, and common was a valvular heart disease, which usually was acquired forms of valvular heart disease related to infections such as rheumatic fever.
Rheumatic fever is something that we don't really hear a lot about today. You mentioned about the impact of ageing, but could you tell us a bit more about how rheumatic fever affects the heart, Will?
Yes, so rheumatic fever is an immune reaction to certain infections, particularly those caused by streptococcal bacteria. For example, if a lot of people get bacterial tonsillitis, that's streptococcal. And these can lead to this reaction when they don't get the treatment they need. And of course, these kinds of infections occur much more commonly in children than adults. I've been a doctor for the best part of 15 years. I don't think I've ever seen a case of active rheumatic fever, though I've seen plenty of people who've had it earlier in their lives. And the reason for that is because since the 1950s, we've had widespread access to antibiotics, so we don't generally let streptococcal infections get to that stage. It's a different story in other parts of the world, but in the UK, we've seen a dramatic reduction. However, 100 years ago or so, more hospital beds are occupied by children with rheumatic fever than any other infectious illness, and it was often fatal. For example, I had an otherwise fit and well great-uncle who died of rheumatic fever at the age of 14 in the 1930s, and I'm sure many families will have similar stories. But even those who survived the initial phase were often left with after effects that could be life-limiting.
What's the connection then, Abdul, between rheumatic fever and the heart valves or heart disease?
So one of the main features of rheumatic fever was it was a condition that would develop following a throat infection from a bacteria, and it could affect several organs in the body. But with regards to the heart, it would be an immune reaction from the body trying to attack structures within the heart, and these structures were the valves predominantly. Now, valves within the heart are like akin to doors which open and close, and they allow blood to flow in a one-way system. And we have 4 valves in the heart, 2 on the left side of the heart and 2 on the right side of the heart. And the main valves that were affected were predominantly in the left side of the heart. And this scarring that would develop following a period of rheumatic fever would develop quite slowly over a decade or more and lead to problems later in life. Usually, though, they would be in the 3rd or 4th decade of life. And what the scarring did was it would lead to thickening of these valves. And so the valves would either not open properly, in which we call stenosis, or they would not close properly, in case they were leaking and they were regurgitant. Now, what that did was over a period of 20, maybe 30 years in some cases, would lead to symptoms of people getting breathless, because these valves would then affect the flow of blood in and out of the heart and the ability for patients to have adequate blood flow. Now, what consequence this had was over a period of time, people will then present with severe rheumatic valvular heart disease, and that's the main impact that rheumatic fever had. Now, even to this day, the World Health Organization estimates there are about 55 million people within the world who are affected by rheumatic heart disease, and it still kills around 350,000 patients, and it's mostly affecting people in sub-Saharan Africa, parts of Central Asia, Indian subcontinent, and we see much less frequently rheumatic heart disease in England, Wales, and Western Europe. So it's certainly a condition that was very prevalent from the late 19th century and early 20th century, but it's something that's become much less common now, but still we do see occasional cases.
So, Will, in the 1950s, what kind of treatments were available for heart valve disease?
Well, like now, there were no medicines that can fundamentally treat heart valve disease. So then and now we rely on procedures to repair or replace the valves. Heart surgery was really a late developer compared to surgery on other areas of the body. And by 1900, surgeons were operating on pretty much everything except the heart because it was just seen as too high risk. But gradually attempts were made, and for narrowing of the mitral valve, a technique called valvotomy was developed in the 1920s, though it only became mainstream decades later. Mitral valvotomy involves opening the chest to reveal the beating heart, quickly making a cut in the side of it, using a special knife or simply a finger to break down the narrowing, before quickly sewing everything up to stop the patient bleeding to death.
That kind of surgery on a beating heart sounds incredibly risky, Abdul.
Yeah, I mean, unfortunately, in that era, that's what was the only option to treat severe mitral valve disease. Now, the mitral valve, as I said, is like akin to a door, and it sits between 2 chambers within the heart on the left side of the heart called the left atrium and the main pumping chamber called the ventricle. And this valve would become very narrowed and would not allow sufficient blood to enter the main pumping chamber. So individuals would not be able to have enough blood flow getting around when they were doing simple things such as climbing the stairs or doing their ordinary tasks, or even for that matter, exercise. And one of the hallmark things, and some of our older listeners may be aware, that often children were forbidden from undertaking physical exercise or PE in those days when they had been affected by rheumatic fever and rheumatic heart disease. And one of the other features that people would have remembered in those days would have been a condition called St. Vitus dance. So when you had rheumatic fever, you knew you had it because you had these uncontrolled jerky movements of the body, which was well appreciated by not just healthcare professionals, but by the people affected by this.
I imagine that this kind of surgery was only really done in the very, very specialist centres in the 1950s. Did we do much of this kind of thing in Sheffield?
You're right that it wasn't done in all that many places, but in fact, Sheffield had 2 surgeons performing mitral valvotomies by the 1950s. We're going to talk a little bit about both of them in this episode. They were both born, like me in fact, in the Bristol area, but spent most of their lives in Sheffield. Alan Fawcett was a First World War Royal Navy veteran serving on the destroyer HMS Tigress, and he'd studied medicine in Edinburgh before becoming consultant surgeon at the Sheffield Royal Infirmary. And that building's still there. It's the ornate Georgian building you now find with the Tesco supermarket in its grounds on Infirmary Road. And Fawcett was fated as a superb technical surgeon and developed a specialism in chest diseases. Now, up the hill from the infirmary was the much more low-key institution at the former workhouse in Fir Vale, which became known as the City General Hospital, and then from 1967, the Northern General Hospital as we know it now. And here at the City General was a surgeon called Judson Chesterman, who'd qualified from Bristol Medical School. His studies there had been interrupted by developing tuberculosis of the lung, and he had to in fact spend time recovering in a Swiss sanatorium. And this may have led to his lifelong interest in treating chest disease. We know from records that he was also performing about 80 mitral valvotomies a year by the mid-1950s, and there was about a 5% chance of dying in hospital after these, which, in honesty, for heart surgery of that time doesn't actually seem too bad.
Abdul?
Yeah, no, I think Will makes a very important point. I mean, all of the conventional modern heart and lung surgical units that have developed in the country over the last decades originally spouted from tuberculosis sanatorium, and surgery originally started on the chest from complications of tuberculosis, but the surgeons then evolved from being thoracic surgeons to then becoming cardiac surgeons and cardiothoracic surgery, and that's how things evolved.
Yeah, that's right. I completely agree. And even today, most cardiac surgeons will also study surgery of the chest. But the other factor was that we had new treatments for tuberculosis. So we had isoniazid, a new kind of antibiotic that could treat tuberculosis. And so the surgery in some ways became less important. But then they had all these other patients with things like valve disease that they couldn't do anything about. And so the focus in some ways shifted to that. So that was a reason for this branching out into these new areas.
So am I right thinking about Chesterman that he was also performing some operations on children at the time, children born with heart defects?
Yeah, that's right. We know from his list of operations that he was carrying out procedures to deal with something called patent ductus arteriosus, which is where there's a persistent abnormal connection between the blood vessels exiting the right and left sides of the heart. Babies born with it often do reasonably well to start with, but then as they get older, and if it's left untreated, it can lead to heart failure and an early death, often by increasing the blood pressure on the side of the heart that pumps blood to the lungs. And it seems he was doing about 10 or 20 of these a year.
So in fact, we're going to hear from Brenda now, who had one of these operations at the City General as a child, and she very kindly agreed to share her story with us.
The original diagnosis must have been through a heart murmur, but I know I then went into hospital in October 1959 when I was 6. I know I was in the children's ward, which was Ward 16, for about 10 days. And then after that, I was moved to a women's surgical ward, and that's where I had the operation performed by Mr. Chesterman. The incision was through my back, and I had 19 stitches. The scar now is 12 inches long. At the time, it must have been a difficult decision for my parents, but since then I've led a very normal, healthy, active lifestyle. I've got 2 grown-up children, and at 71, I'm now a keen runner. I park run every Saturday. I regularly take part in 10K events, and I've done 3 half marathons. And this is all thanks to Chesterman, really. I owe him a great deal, and I'm sure that my lifestyle might have been very different had he not performed that operation.
What a remarkable story. Is that a typical kind of story from someone that was operated on by Chesterman at that time?
It would have been for those selected surgeries that were able to be performed without a heart-lung machine, because it was a relatively simple defect that needed repair, and clearly it had a huge impact on the long-term survival of these patients.
Was that a typical kind of story of the time?
It was at a time when surgery was becoming available for the treatment of patients with congenital heart defects. Now, I think it's important just to illustrate what congenital heart defects are. These are deformities clearly from birth within the chambers of the heart, either holes or abnormal plumbing, and it ranged from very simple forms of congenital heart disease to very complex forms. And the more complex forms were often associated with low oxygen levels within the blood, because the circulation on the right side of the heart and the left side of the heart would mix, and so they would have blue babies because of the cyanosis. Now, until the 1940s and 50s, these patients would have rarely gone into hospital, and often they were told that nothing could be done. And parents would protect and shield their loved ones from going into hospital and being objects of medical curiosity, because they knew that nothing could be done. And the more severe forms of congenital heart disease, sadly, these infants would die either in very early infancy or early childhood, depending on the severity of the defect. There were some simpler defects that children could live with for 10, 20 years. And the introduction of heart surgery, particularly in the United States and then subsequently within England, initially starting in London and several other centres across the UK, including Sheffield, really began the introduction for an important treatment and potential cure for these conditions.
Clearly, there were many successes, and it's absolutely fantastic to talk to people whose lives have been changed. Things were still very difficult, and for more complex defects, and in a lot of cases where things we would regard as relatively straightforward now, there were things that could go wrong. And rather like now, it was about choosing who to do the operation on, and there were many cases where unfortunately nothing could be done.
So how was Chesterman finding his patients then in this era of shielding children, or kind of the narrative that nothing could be done?
Sure. So, I mean, we had the NHS in 1946, and prior to that, healthcare was probably less organised than it did following the introduction. And at the time, the Sheffield Regional Health Board, which was one of 14 for England and Wales, and this was constituted under the NHS Act in 1946, and its main purpose was to organise the administration of hospital and specialist services in South Yorkshire, Lincolnshire, North Derbyshire, Leicester and Nottingham. And one of the things that they wanted to do was to set up a regional cardiovascular centre of expertise, and this was developed in the early 1950s. And so the next step for them was to appoint somebody who would be the regional cardiologist to look after these patients. Now, cardiologists are doctors who look after aspects of heart disease, particularly before a patient was to undergo any form of surgery. And as we've just mentioned, surgery was on the horizon and emerging as a treatment for these patients. Now, in 1952, an eminent physician called Dr. James Brown was appointed to this role, and he had developed an expertise in caring for children with rheumatic heart disease and congenital heart disease. I'd like to just share a little bit about his background. He was born in Gloucestershire. He was a family of Quakers. He served in the French Red Cross in the First World War and then graduated from the Middlesex Medical School in 1923. A year later, he moved to Lincolnshire as a GP to work with his father-in-law, and during that time he developed an interest in caring for children in school clinics. So he was appointed as a physician to these school clinics to look after children with rheumatic fever and heart defects. And I think that was a really important step because, as we know, the parents didn't want to take their children into hospital in those days. And actually, by caring for them in the school, he managed to gain a huge amount of experience and exposure in looking after these children. And his experience over the next 10 years was collected, and he published the first clinical textbook of his experience in congenital heart disease. And it was the first book that was actually published on the subject within certainly the UK and the Western world. Now, it was a very important textbook, and it described the clinical features, the bedside features. It would use simple investigations such as an ECG, an electrical recording of the heart, and simple things like a chest x-ray. But also, James Brown worked as a pathologist. He was appointed to the Grimsby Hospital and hospitals in Hull and North Lincolnshire. And so he also was involved in understanding the anatomy of these hearts and sadly these children that passed away. As a consequence, he amassed a huge experience, and he was appointed to be the regional cardiologist to this new Sheffield centre, and in fact was the only applicant. I suppose reading between the lines you would think he was probably headhunted because there was nobody else who knew the subject matter so well. And more importantly, he was a travelling cardiologist. He worked in clinics in Leicestershire, the Groby Road Hospital, which is now Glenfield Hospital, which was also a TB and a chest hospital, in Nottingham, times in Leeds. And following his appointment, he really wanted to bring together this experience that he had, but with the transition into the modern age where modern techniques were being developed. And he wanted to bring that and centralize that within Sheffield. So they wanted to develop a thing called cardiac catheterization, which involves passing a tube, like a spaghetti wire, through the vein or an artery in your arm or leg. And this would be passed into the heart to measure pressures. Now that sounds quite scary, and it probably was. In 1929, the first individual to perform this was a chap called Werner Forssmann in Germany, and he wanted to prove the point that he could pass a catheter or a tube from the vein in his arm to his heart, and he managed to do that. He ran up a flight of stairs, went to the x-ray department and had an x-ray taken to demonstrate that it could be done and that you could still be alive and talking. And unfortunately, though, he was dismissed from his department because he was felt to have contravened rules. He was subsequently awarded the Nobel Prize in the 1950s, along with two other cardiologists from America, Andre Cunard, for this revolutionary step. Now, with the advent of cardiac catheterization, it was made available and others were keen to learn, and this is what James Brown wanted to do. I like to bring in another fellow cardiologist called William Whitaker. He was a Yorkshireman, and he trained following the war with a very eminent Dr. Paul Wood, who was a cardiologist at the National Heart Hospital in London. And he developed cardiac catheterization and studied these children with these congenital heart defects. And when he moved back to Sheffield at the Royal Hospital, which is on the West Street, he worked with James Brown, and James Brown had this large collection of patients with acquired and congenital heart disease, and he was bringing them to Sheffield to care for them and to determine which of them could undergo heart surgery.
So, Will, what were the issues here? It sounds like we're making progress, getting good results, patients are being identified. What were the medical issues that needed to be resolved?
There are a few issues. Though there were operations for quite straightforward congenital heart problems and for narrowing of the mitral valve in particular, these were only really suitable for certain cases that were fairly uncomplicated. And even in those cases of valve disease they could treat in those days, the valve could narrow again after the operation. Also, if there's leaking of a valve, valvotomy, for example, would only make the problem worse. It just opens the hole even more. So there are many cases where valvotomy wasn't sufficient or appropriate. And it was recognized that this was a severe limitation and people working on other solutions. In the early 1950s, a surgeon called Charles Hufnagel, working in Boston in Massachusetts and later in Washington, D.C., developed an artificial heart valve for treating regurgitation or leaking of the aortic valve, which he implanted downstream from the heart to prevent backflow of blood whilst the heart was filling. And these valves were made from perspex. They looked a bit like a ping pong ball inside a clear tube, and we'll put a picture on the web page. They click loudly with each heartbeat, which I think genuinely drove some patients to insanity, and would only partially solve the effects of the leaking aortic valve, but it was certainly a start.
So they clicked.
People may be familiar with heart valves that click now, and if you're in a very quiet room with a patient who has a metal valve, you can certainly hear it click. But this, I think, was a real loud kind of throaty click that accompanied every single heartbeat for the rest of that patient's life.
Not only drove the patient mad, it must have driven the family mad as well. So anyway, well, Perspex, it seems like a really difficult and brittle material to work with. Why on earth make this out of Perspex?
Fundamentally for two reasons, I think. First, it can be highly polished to a smooth finish, which they hope would avoid blood clotting on the surface. Also, they noted how in the Second World War, Perspex aircraft canopies could shatter and embed themselves in airmen, which obviously caused a lot of injury, but the fragments themselves didn't actually cause a reaction. The immune system would tolerate them, and we'd now call this a biocompatible material. And notably, just before this, in 1949, Perspex had also been used successfully to make the first artificial lenses for cataract operations.
So why are we talking about American Perspex heart valves on a podcast about Sheffield?
Alan Fawcett at the Royal Infirmary clearly became aware of Hufnagel's work when it was still at an early stage, and in fact he was so intrigued that in 1952 he got on the RMS Queen Mary and he travelled to visit Hufnagel and colleagues for 6 weeks or so. He returned with some of these artificial valves and implanted them into 4 patients with end-stage aortic regurgitation, starting initially in 1955. And actually he wrote these cases up in the Postgraduate Medical Journal. You can still find them today online or in the original print copies. And though these cases highlighted a lot of the problems of this early valve replacement, one in particular did reasonably well, and these operations, we believe, represent the first time an artificial valve had been implanted in the UK, which is a real milestone.
So how about Chesterman then? What was his contribution to this?
Chesterman presumably knew about the work of Hufnagel, but he recognised that this approach could not be used for treating problems with the mitral valve. The mitral valve sits between the top and bottom chambers of the heart, and any artificial valve to replace it needs to sit in that location too. And Hufnagel's design of a long tubular valve with the ping-pong ball in it is the wrong shape and it simply won't fit. So Chesterman set about designing an artificial mitral valve himself. It's been said he might have got the idea for his design from the poppet valves of a car engine, though I spoke to Mr. Chesterman's daughter a few years back and she certainly didn't seem to think he showed any particular interest in car maintenance. And we still have his final design drawn out on yellowing ruled paper in his blue and red fountain pen.
So he designed the valve, but did he produce any from the drawings he made?
Yes, he initially approached the hospital plumber who made some out of copper piping, presumably offcuts used to sort of plumb in a toilet cistern or something, but realised these were far too crude to possibly be suitable for implanting into people. And then he teamed up with a rather clever chap called Cliff Lambourne, who was the hospital pathology technician and a dab hand with machining. Lambourne only had access to a giant lathe, he later referred to it as his monster lathe, to turn this tiny elliptical medical prosthesis, which is no mean feat to achieve. And again, this time, the material they used was Perspex.
So I think you've got a story about Cliff Lambourne taking his work home with him.
Yeah, that's right. Cliff Lambourne recounted making the finishing touches years later in the hospital newspaper, and this is what he said. Turning left a roughish surface and it had to be smooth. I tried various sandpapers, but the valve had to be smoother, and I realised it was going to take a lot of work. At that time, the cinema was still showing some very good films, and my wife and I were keen cinema goers. We sat in the cinema, watching films, me with a piece of silk cloth in my hands, polishing the pieces. I put a fine abrasive on the cloth, and it took about 3 feature-length films to get the valve smooth enough.
I wonder what he was watching. We can only guess, I assume. What happened next? Did this device get into a patient?
The finished valve was indeed implanted into a patient, a 34-year-old man with terminal mitral valve disease, and that was on the 27th of July 1955. Now, it's important to realise that he had no way of stopping the heart and taking over the circulation with a bypass machine like we would do now, so he had to work quickly on a beating and bleeding heart and couldn't at all see well what he was doing. He removed the patient's mitral valve and put the artificial valve in its place, and he actually secured it with 2 Perspex buttons sewn to the outside of the heart. Initially, the valve did work well, and the patient woke up, and it said he was able to read the evening paper. but in the night he suddenly deteriorated and died.
That's really sad. What did they find out what went wrong?
Yeah, a post-mortem examination was conducted, and this showed that the valve had dislocated, which had brought about the patient's demise.
What happened to the valve?
Well, while it might be frowned upon now, the patient's heart, with the artificial valve still in it, was kept in the Hospital Pathology Museum. When it became realised that it was unacceptable to retain specimens like this around the turn of the millennium, a wonderful pathologist called Professor Kim Savannah, who very sadly died in 2023, rescued the valve from the heart, which itself was sent to be destroyed, and kept it safe, so we've still got it today. And it remains acknowledged as the first mitral valve replacement operation in the world.
So did Chesterman give up at that point? Did he carry on doing other procedures and developing the procedures?
Though we know he continued to work on different valve designs with Cliff Lamborn, in the end I don't believe he attempted to implant any artificial valves again. But we know from his written reflections that he recognised the need for a way to stop the heart and lungs to perform open heart surgery for these kind of complex heart operations to have a better chance of success. Now this would involve taking over pumping of blood around the body whilst also oxygenating the blood. In other words, a bypass machine or a heart-lung machine. And Chesterman convinced the hospital authorities to give him £250 towards building a machine of this type, equivalent to something like £8,000 today. At that time, only a few teams in the world were working on this problem, which needed to combine something to pump the blood with something to oxygenate it. Reasonably good pumps had been developed, for example, the Sigma motor pump, which simulated fingers coaxing blood along a tube, or the roller pump of Michael DeBakey, but it still remained very difficult to use these safely in practice. And oxygenating the blood was even more difficult. There were very expensive methods of screen or disc oxygenation that had been developed, but availability was really limited to a couple of centres worldwide, and at about $60,000 each. These were vastly outside the budget of the City General. In Minneapolis, a group led by Walton Lillihei were experimenting with a couple of alternatives to these very expensive machines. Famously, they'd tried hooking up the circulation of a child to be operated on with that of a healthy, compatible donor, usually a parent, and these were known as cross-circulation operations, and they did quite a few of these. But this ran the risk, which unfortunately was too often realised, of both dying if something went wrong. Tasked with finding an effective alternative at a reasonable cost, Lillihei's research fellow, a guy called Richard DeWall, was developing a method that dissolved pure oxygen into the blood and then removed any excess bubbles by passing it down a long helix of tubing. Chesterman actually visited Minneapolis in early 1956, and we've still got the notes he took, and he sketched the DeWall oxygenator in use with its measurements and the equipment needed to create it. And he got to have a go with it in the laboratory. And convinced this was a viable method for his own work, the hospital's £250 was used to buy the pump, a Sigma motor type, whilst he assembled the oxygenator equipment himself from his own pocket.
Did he ever use the machine?
Yes, though it took another year to get everything in place, but when he did, he was probably only the second in Europe to use one of these bubble oxygenators. He was referred a 44-year-old umbrella maker who was getting short of breath on exertion and had findings on clinical examination consistent with severe narrowing of the mitral valve. Now, on the 15th of February 1957, he took her to the operating theatre to, in fact, perform a mitral valvotomy. But in fact, rather than finding a narrowed valve, he found a golf ball-sized tumour, and he couldn't do anything about this at the time and closed everything up. Now, this kind of heart tumour, which we still see today, the technical term is an atrial myxoma, it's not a cancer, but it'll gradually grow and lead to death by obstructing the flow of blood within the heart if it's not dealt with. So her prospects were sadly very poor. The only way to remove it would be with an open heart operation, and so he decided this was the time to try his machine. So on the 26th of February 1957, he used the machine to remove the tumour. In fact, the machine worked pretty well, although there was a lot of bleeding during the operation. The patient needed 19 pints of transfused blood. The heart was weaned off the machine and the patient was awake afterwards with a good blood pressure, but unfortunately deteriorated in the evening and died that night.
So it really does sound like these early operations were pretty grim. Was Chesterman just unlucky?
It's difficult, isn't it, to weigh up these things. Clearly in these cases there was not a good outcome. But to put it in the global context, it's reckoned that out of the first 18 cases of operations using a bypass machine around the world, 17 didn't recover. Yet today, both the heart-lung machine and the artificial valve are absolutely key components to how we treat cardiovascular disease. So they were certainly on the right lines, and these early forays into heart surgery were crucial in exploring these concepts that turned out to be fundamentally correct. I say they were fundamentally correct, but it's also taken a huge amount of further development, not only in the design of artificial valves and in surgical techniques, but also, for example, in methods of diagnosis, imaging, and in pre- and post-operative care. Combined with the fundamental approaches, this is how we've got to where we are at the moment. And I think it's also important to recognise that these techniques were only tried in cases where there was no other hope. We certainly do need to pay particular tribute to those patients who underwent these experimental procedures so that others after them could benefit.
So to understand much more about how heart valve disease is treated today, we asked one of your colleagues, Mr. Norman Briffa, consultant cardiac surgeon at the Northern General.
My name's Norman Briffa. I'm a consultant cardiac surgeon here in Sheffield. I'm actually a Sheffield graduate. I have a particular interest in heart valve disease, and I have been president of the British Heart Valve Society a few years ago. Today, artificial heart valves are absolutely central to the treatment of patients who have significant heart valve disease. The designs have evolved significantly since the first mitral valve operation performed by Mr. Chestnut to the Hafnagel valve. But the principles remains the same. Essentially, they're devices that open to allow forward flow of the heart, and then when the pressure builds up, the valve closes to prevent retrograde flow. We use a heart-lung machine, and we routinely perform open heart surgery here in Sheffield. It allows us to open the heart, remove the disease valve, and sew in new artificial valves. In Sheffield, we perform around between 800 and 900 open heart operations per year, and probably about half of those involve either repairing a valve or replacing a valve. Whereas in the 1950s, most heart valve disease was caused by rheumatic fever, most of it is now caused by aging. And in actual fact, as the population ages, the number of patients with significant heart valve disease is increasing quite rapidly. Our results are clearly much better than those achieved 50, 60 years ago. And for the commonest type of heart valve operation, we quote a risk of dying from the surgery of less than 2%. But clearly we wouldn't have got to this point without the pioneering techniques used by Mr. Chestman and Mr. Fawcett, practicing all these steps all those years ago in Sheffield.
So what strikes me is that not only the fundamental principles don't appear to have changed much, but also that valve disease has not become less of a problem. He was saying that increasing numbers of older people were suffering from heart disease. I presume you need to be quite fit to recover well from open heart surgery. If people aren't up to that, what are the options?
You're certainly right that we're picking up and treating a lot more valve disease in older people, and certainly when I started training, if someone wasn't fit for open heart surgery, there was little we could do to help them. For severe narrowing of the aortic valve, which is the valve problem associated with the poorest outlook, we do now have the option in some people of performing what's called a TAVI procedure if someone isn't fit for an open heart operation.
And we'll hear a bit more about this from Mel Neville, who's a nurse specialist in the TAVI team at the Northern General Hospital.
Transcatheter aortic valve implantation, or TAVI, is a treatment for severe narrowing of the aortic valve. Without treatment, the outlook for patients with this kind of valve disease is unfortunately very bad. While open heart surgery is still the first-line treatment for narrowing of the aortic valve, in a sizable number of patients who aren't suitable for that, TAVI can give them a second chance. This often includes patients who are older or those who have other health problems and people in the past we've not been able to help. TAVI involves inserting an artificial valve into the heart through a small hole made in the artery, usually at the top of the leg. It can usually be done whilst the patient is awake. We've only been doing this in Sheffield for just over 8 years, but last year we did 270 cases, and that's growing all the time, hoping for 300 plus this year. Here at the Northern General, we have pioneered doing the TAVI procedure as a day case in certain people, and also have helped introduce a new kind of artificial valve. My job as a TAVI nurse specialist is to guide patients through the journey from diagnosis to assessment, through the procedure and into their recovery. I find it really rewarding to see how people improve after they've had their treatment, and patients are always very grateful for the new lease of life we can give them.
So rather like Chesterman and Fawcett performed their first valve replacements on a beating heart, we're now doing that again, but I presume with much better results.
Indeed, and in due course I've no doubt that doctors in Sheffield will be performing a range of other valve procedures using similar techniques.
So it's been really fascinating to learn about valve disease and how the work of two Sheffield surgeons in the 50s continues to resonate today. Just one last thing, I've heard of Chesterman. There's a building named after him, but I haven't heard of Fawcett. Why is that?
It's a good point, and I think many people will be the same. Chesterman, as you say, is remembered now through the Chesterman wing at the Northern General Hospital, which houses the South Yorkshire Cardiothoracic Centre. In fact, the naming of it has a story of its own. The convention at the Northern General is to name new wings after the city's steel companies or associated individuals. So we have Firth, Huntsman, Brearley and Vickers, for example. In the 1990s, when deciding what to call the new cardiac unit, it was proposed by the medics to name it after Judson Chesterman to recognise his pioneering work. However, the hospital bosses favoured naming it the Samuel Fox Wing instead, keeping with the steel theme. It was then, of course, pointed out that naming something the Sam Fox Chest Unit would make it a laughingstock. And it was also pointed out that Judson's great-grandfather had in fact been James Chesterman, who'd founded a steelworking business in the Bow Works off Eckersall Road in 1829. And in fact, it was him who invented the flexible tape measure. So a compromise was reached by which it remains to this day quite ambiguous as to which family member the building honours. And I should also say that if you want to read and see more about Chesterman, I've personally recently published a paper on him that's free to access, and we'll put a link in the description. And we've set up an exhibition case, kindly funded by the Sheffield Hospitals charity, in the Chesterman Wing outpatient waiting room at the Northern General that includes some key artefacts, including Chesterman's original heart-lung machine and also a giant replica of the artificial valve, should you wish to come and see them.
Well, that's really fascinating. I had no idea that the history of diseased heart valves, valve replacements had such a story grounded in Sheffield. Where are we going with this medicine? Where can you see the future developments taking us?
Well, I think that's a really interesting question. Open heart surgery currently still has a very central role, but we're doing more and more procedures with keyhole access, and I think those will continue to expand. And it's possible that those will expand to include people who we currently do open heart surgery on. I think we've had this procedural approach to treating valve disease since the beginning. As I said, we don't have any medicines at all that can really do anything about it, and that's an obvious area that needs further work. It's even possible that things like nanotechnology, nanobots and genetic engineering could come into play in the next few decades. And I wouldn't rule out a kind of shift change again into how we do things.
So Abdul, there's a whole side of heart and circulatory disorders that is also grounded in Sheffield, and that's pulmonary hypertension.
Yeah, of course. I mean, you cannot look at the heart in isolation. The heart is surrounded by the lungs. The heart's divided into two sides, right and left, and blood flows through the lungs and back to the left side of the heart. And a condition that affects the left side of the heart that we've been talking about today can often affect the lungs, and vice versa. Conditions within the lungs can affect the heart. So therefore, they're two intimately linked organs, and their physiologies is so coordinated that it's natural that we have to discuss the two together.
I think we need to come back to this topic and next time talk in more detail about pulmonary hypertension. Well, Abdul, this has been really fascinating. Thank you very much for joining me today. You've been listening to the Overend-Knight podcast, and my thanks also go to Mel Neville, TAVI nurse specialist at the Northern General Hospital, and Mr. Norman Briffer, consultant cardiac surgeon at the Northern General Hospital, and also Brenda, who's 71 years old and still going strong. The podcast was produced by Andy Tattersall and Sheila Francis. I'm Alan Pacey. Thanks for listening.